All right, let's talk about one of the most critical moments in any cardiac surgery, weaning from cardiopulmonary bypass. This is it. This is the final approach, the moment the machine hands the controls back to the heart, and we see if the patient is ready to fly on their own. It's a moment that demands absolute precision, a deep understanding of physiology, and really flawless teamwork.
Welcome to the Anesthesia and Perioperative Medicine channel.
Benvenuti al canale dedicato ad anestesia e medicina perioperatoria.
Anesthesia and Perioperative Medicine channel में आपका स्वागत है.
Okay, so here's our flight plan for today. We're going to start with the core principles and preparation, then walk through the standard weaning protocol. After that, we'll get into the tough stuff, how to navigate difficulties, and review our toolkit of drugs and machines. And finally, we'll wrap up by debriefing some real-world clinical cases where the TEE was the absolute hero of the story.
So, let's jump right into part 1, the foundational principles and the preparation. You know, this is all about setting the stage, making sure everyone in the cockpit is ready, and that the aircraft, our patient, is configured perfectly for the landing sequence. So, just to make sure we're all on the same page, let's start with the basics. Cardiopulmonary bypass, or CPB, is that incredible technology that lets us operate on a still, quiet heart. It's our temporary life support system. Our entire focus today is on how we transition the patient off this machine safely and successfully. And you know, this analogy from Licker and his colleagues, it just perfectly frames our entire discussion. Weaning from bypass isn't just another step in a procedure. It's a high-stakes event, just like landing a plane. You've got a coordinated team, the surgeon, the anesthesiologist, the perfusionist, all interpreting a constant stream of data, working together to perform this incredibly complex task, and all under a ticking clock. It's beautiful, really. And that brings us to the human factor. Before we even touch on a single drug or physiological parameter, we have to talk about team dynamics. I mean, we all know poor communication is a huge source of medical errors. In fact, when you look at the data, a huge chunk of adverse events in pediatric cardiac surgery, like 30%, happen right after coming off bypass, and it's directly linked to breakdowns in teamwork. So things like standardized communication, briefings, and simulation training, they aren't just nice-to-haves, they are absolutely essential safety systems. Okay, let's move on to part 2 and see how all this builds into what we can call the standard weaning protocol. Seriously, think of this as the pilot's mandatory, non-negotiable pre-landing checklist. You see, the process begins by making sure a bunch of key prerequisites are met. We are not just flipping a switch here. We are methodically, step-by-step, optimizing the patient's entire physiology for this transition. That means getting them warm, normalizing their blood work, getting the lungs working again, and making sure their heart has a stable and effective rhythm. Every single one is a critical checkpoint. So let's put some hard numbers to that. These are the big 3, the non-negotiable targets. Core temperature has to be up above 35.5 degrees, because everything from enzymes to coagulation just works better when you're warm. The hematocrit needs to be good enough for oxygen delivery, usually somewhere north of 25%, and the heart rate, well, that's a sweet spot, right? We want it between 70 and 100, fast enough for good cardiac output, but slow enough that we're not burning through myocardial oxygen. Okay, let's dive a little deeper into this metabolic and hematologic part of the checklist. We're actively rewarming the patient. We are making sure the electrolytes are perfect, especially potassium, because you do not want to be dealing with arrhythmias right now, and ionized calcium, which is absolutely critical for contractility. We're making sure the pH is above 7.3 to keep the heart happy and the enzymes working. And this last one is huge. We confirm the patient is still fully anticoagulated with an ACT over 400. Reversing that heparin before you are 100% certain you are off bypass for good, that's a mistake you just can't afford to make. And this next part of the checklist, this is where our best friend, the TEE, really comes into play. We're aiming for sinus rhythm, using the pacing wires if we have to. But look at those last 2 rows. This is where TEE becomes our eyes inside the patient. We can directly assess preload by measuring the ventricle itself, which is way more accurate than just looking at a CVP number. And maybe most importantly, we do a final quality control check of the surgery. Are there any new valve leaks, any shunts? We have to know this before we commit to coming off bypass. So once that checklist is all green, the handover begins, and it is this very controlled, gradual process. As you can see on this timeline, we start at 100% CPB flow, the heart's empty, lungs are down. The perfusionist then starts to slowly occlude the venous line, which allows the heart to start filling and ejecting. We're glued to the monitors, watching the pressures, watching the TEE. As we drop the flow to 50%, then 25,
With every step, the heart is taking on more and more of the work until finally, at 0% flow, the pump is off. The patient is flying solo. But as we all know, not every landing is smooth. So what happens when things don't go according to plan? This brings us to part 3, navigating weaning difficulties. This is when our well-laid flight plan hits some unexpected and sometimes severe turbulence.
So what do you do when weaning is difficult? And this isn't some rare event. We're talking about something that happens in up to 45% of patients, depending on who you're operating on. When this happens, you need a rapid, accurate diagnosis and a decisive response. The clock is ticking, and the risk of damaging a poorly perfused heart is very, very real.
Now, the good news is these difficulties almost always fall into one of 4 distinct buckets, which we've laid out right here. First, you might have a surgical or technical failure, which TEE is absolutely brilliant at spotting. Second, and this is the most common one, is ventricular dysfunction, a classic pump problem. Third is vasoplegic syndrome. This is a problem with the pipes, where the whole system is just too dilated. And fourth is a dynamic issue, like an LVOT obstruction. Each one has its own unique signature on TEE and hemodynamics that points you right to the correct diagnosis and, more importantly, the right treatment. Okay, let's zoom in on vasoplegia for a second. What's really interesting is when you look across all these studies, a really clear pattern of risk factors starts to emerge. Notice the same things keep popping up over and over. Pre-op ACE inhibitors, poor LV function, a long time on bypass. This data lets you build a mental picture of the high-risk patient, right? Someone with heart failure on an ACE inhibitor, coming in for a long, complex valve job. If you can anticipate this, you can be ready with your vasopressors before the problem even starts. And it's a very similar story for post-CPV ventricular dysfunction. Again, a clear consensus appears in the literature. Patient factors like being older or having a low LVEF to begin with, and procedural things like a long aortic cross-clamp time are all major predictors. This knowledge is everything for risk stratification. If you've got an elderly patient with a weak ventricle and you know it's going to be a long case, you should already be thinking about your inotrope plan way before you even start the weaning process. All right, so we've identified the problems. Now let's move to part 4 and open up the pilot's toolkit. This is where we cover the pharmacologic and mechanical interventions we use to manage that turbulence and get the patient safely on the ground. Our response here is not random. It follows a very logical, stepwise algorithm. First, go back to basics. Re-verify the entire checklist. Is the patient warm? Are the electrolytes normal? Use your TEE to immediately roll out a surgical screw-up. Second, optimize preload. Use the TEE to make sure the ventricle is full but not overdistended. Third, start your drugs, but tailor your choice to what you're seeing on the screen. And finally, if the drugs just aren't enough to get you to your perfusion goals, it's time to escalate to mechanical support. Now, this table is our pharmacological toolkit, but the key isn't just knowing the drugs. It's about choosing the right tool for the job based on your diagnosis. So if your TEE shows a big, baggy, globally hypokinetic ventricle, a classic pump problem, you're going to reach for an inotrope like dobutamine or adrenaline. But if your TEE shows a hyperdynamic, well-contracting heart, but the blood pressure is in the tank, that's a classic pipe problem. That's vasoplegia, and the answer there is a vasoconstrictor, like norepinephrine. Then you've got your specialty tools. If TEE shows an isolated RV failure with a big, dilated RV, something like milrinone is a great choice because it gives you inotropy, but also helps dilate the pulmonary arteries. The strategy isn't just to give a drug, it's to give the right drug for the TEE diagnosed problem. But sometimes the drugs just aren't enough. So when do we pull the trigger and escalate to mechanical circulatory support? The answer is pretty clear. When you have persistent low cardiac output syndrome, so a cardiac index below 2.0 with signs of organ malperfusion, and you've already tried to fix it with drugs. The most important thing here is not to wait. Delaying this decision can lead to irreversible multi-organ failure. And just like with the drugs, the choice of which device to use is not a guess. It's driven by a clear algorithm based on what you're seeing. Is it a total cardiorespiratory collapse? Well, then the answer is VA ECMO because it supports both the heart and the lungs. Is it isolated RV failure on the TEE? And RV80 is the right call. Both ventricles are failing? You need biventricular support, or again, VA ECMO. And for isolated LV failure, the traditional workhorse has always been the balloon pump, with more powerful devices like LVADs for the really tough refractory cases. And this table really lays out the whole landscape of our mechanical support options. The key concept to understand here is the trade-off. On one end of the spectrum, you have the IABP. It's pretty easy to place, but it only gives you a little bit of support, and the heart has to be doing some work on its own. On the other end, you have VA ECMO.
It provides incredible biventricular and respiratory support, but it's a lot more invasive and carries higher risks of bleeding and hemolysis. The choice is always about balancing how much support the patient needs against the invasiveness and the potential complications of the device.
Okay, for our final part, let's put all this theory into practice. We're going to step into the flight simulator and run through a few real-world cases. This is where you really see how TEE helps us apply all these principles when we're in the middle of a crisis.
So for each of these 3 cases, we're going to follow the same debrief format. What was the clinical problem we were facing? What was the definitive diagnosis we got from the TEE? What was our response strategy? And what was the ultimate role that TEE played in getting us to a successful outcome? Okay, case 1. Imagine this. You're starting to wean and suddenly the bottom falls out. You have catastrophic hypotension and ST elevation on the monitor. Is it a graft failure? Severe ischemia? The differential is huge, but the TEE gives you the answer instantly. The left ventricle is completely full of air. This isn't a physiological problem, it's a mechanical one. The response is immediate, back on full bypass, get the patient head down in Trendelenburg and aspirate that air. TE's role here was literally life-saving. It gave us an unambiguous diagnosis in seconds and then confirmed we got all the air out before we tried again. Now, case 2 is a bit different. Here, the problem starts before we even try to wean. The team is having trouble maintaining pressure on bypass, and the LV is paradoxically getting bigger. TEE reveals the diagnosis. There's a new, massive jet of aortic regurgitation that's overpowering the LV vent. This is a surgical failure. Without TEE, the team might have tried to wean and gone directly into immediate refractory cardiogenic shock. Instead, TEE found the problem early. It acted like a quality control check that sent the patient back to get the valve fixed, and it prevented a failed weaning attempt altogether. And our final case is a really elegant one. After a mitral valve repair, the patient weans successfully at first, but then becomes severely hypotensive. Now, your natural instinct might be to start inotropes, right? You're assuming it's ventricular failure. But TEE tells a completely different story. It shows systolic anterior motion, or SAM, where the mitral leaflet is getting sucked into the LV outflow tract, causing a dynamic obstruction. The LV is actually hyperdynamic. In this case, inotropes would have made everything worse. Guided by the TEE, the correct response was medical. Give more volume to fill out the LV and stop the inotropes. TEE didn't just point to the right therapy, it actively prevented us from giving a harmful one. So the ultimate takeaway from all of this is that the safest landings combine a systematic, checklist-driven protocol with the incredibly powerful, real-time diagnostic eye of TEE. This whole approach moves us beyond just treating numbers and toward a precise, physiologically based strategy. So the final question I'll leave you with isn't just if you're prepared for a safe landing, but when that unexpected turbulence hits, will your diagnosis be fast enough to change the outcome?